Hello, everyone, and thank you for joining us this afternoon for our fifth week of the Rugby Research and Injury Prevention Group 2025 Analytical Series. Our first intern is Gabriel from Adelphi University. Gabriel will be presenting on the attributable risk and number needed to harm, calculating odds, and calculating odds ratio. Gabriel, will you please share your screen?
Like Lauren said before, my name is Gabriel Moreno, and today I'm gonna be presenting on attributable risk, numbers needed to harm, calculating odds, and calculating odd ratios. So let's begin. Before I start, I want to give a brief introduction as to why this matters, like why does attributable risk or why does number needed to harm, why do these things matter? The reason why is because they help us measure how much of a risk factor or how much could an intervention, let's say a vaccine or protective gear in rugby, how much does this actually influence in the results that we get in the real world? This could be useful for public health, for epidemiology, for clinical decisions, and to help us understand studies when we see this vocabulary or these things come up in different charts and diagrams that we'll see. So to start off, one of the important key terms to understand is going to be incidence. So what is incidence? Incidence is the rate of new cases or events that happen over a specific period of time for a specific population that's at risk for this event. So in brief, just think how many new cases of a disease occur in a specific group over a certain time period. So in a year, imagine 20 out of 100 smokers get lung cancer. The incidence is going to be 20%. To calculate this, it's going to be the number of new cases of that disease during that time period over the total people at risk at the start of the period. So 20 over 100, and you get the incidence of 20%. Now let's move on to relative risk. So relative risk is going to compare the risk of a disease between two groups, the exposed group and the non-exposed group. So the formula for this is going to be risk in the exposed group divided risk in the exposed group over risk in the unexposed group. So in this case, let's imagine these numbers are just made up just for the convenience of our examples. So 20% of smokers get lung cancer and 2% of smokers don't get lung, or 2% of non-smokers get lung cancer. So in this case, it's going to be 20% divided by 2%, and it's going to give us 10. So in this case, we're going to interpret this as smokers are 10 times more likely to get lung cancer than non-smokers. Now moving on to attributable risk. So AR is going to be another way to compare both groups. It's the incidence of disease in the exposed group that can be attributed to the exposure. So how much of this is caused by the smoking? So the formula for this is going to be the risk in the exposed minus the risk in the unexposed. So in our example, again, we said 20% of smokers get lung cancer and 2% of non-smokers get lung cancer as well. So in this case, it's going to be 20 minus 2. And that 18% is going to tell us that out of the people who get lung cancer, 18% get it directly because of smoking, and that 2% get it for other factors that aren't smoking. Now, moving on to absolute risk reduction. Now, this is almost like the opposite of the previous one. So ARR is going to be used when an intervention protects against a disease. So imagine us wearing a scrum cap in rugby and how that helps protect against maybe cauliflower ear or concussions. So ARR is going to equal the incidence in unexposed minus the incidence in the exposed group. It's the reverse. So let's imagine this scenario to help us understand it better. So this is a study that looks at whether wearing seatbelts reduces the risk of injury in car accidents. This isn't real data, it's just made up. So the incidence of injury in the drivers who didn't wear seatbelts, so they weren't exposed to the intervention, it was 10 out of 100. But the drivers who were exposed to the intervention wearing the seatbelt, it was 2 out of 100. So 10% minus 2% is 8%. The way we interpret this percentage is going to be that wearing a seatbelt reduces the risk of injury by 8% compared to not wearing one. So now let's look at attributable risk percent. So this is going to be the percentage of risk in the exposed group due to exposure. To make this a bit simple, of all the people who got sick in the exposed group, what percent got sick because they were exposed to this smoking or because they're exposed to this variable? To calculate this, is going to be ARP equals attributable risk divided by the incidence of disease in the exposed group. So like we said before, 20% of smokers got lung cancer, and we have a attributable risk of 18%. So what we're going to do is put that 18 over that 20, that's going to give us 90%. So out of the total people who got lung cancer, this is going to tell us that 90% of these cases is due to smoking. Now, what's the number needed to harm? This is going to tell us the number of people who need to be exposed to discerrent variables, say who need to be exposed to lung cancer for one person to be harmed or for one person to develop lung cancer. I mean, sorry, who were exposed to smoking to develop lung cancer. So to calculate this, it's pretty easy. You just put one over the attributable risk, and in this case, it's not going to be expressed as a percentage. It's going to be expressed as a decimal. So in our case, it's going to be 1/0.18, which is going to give us around 6. So based on this, if 6 individuals start smoking, then one will eventually develop lung cancer. Now, on the opposite end, we have number needed to treat, which is which is going to be how many people needed treatment to prevent one bad outcome. It's basically the exact opposite because number needed to harm is how many people need to be exposed for one bad outcome. Both of them have the similar formula, so it's going to be 1 over the absolute risk reduction or 1 over the attributable risk. Now let's expand a bit more on number needed to treat. So an ideal treatment or therapy or intervention is going to have a value of 1 because it would achieve the desired effect for every individual. So let's say for every individual who wears protective gear, they don't get injured. Or let's say for every individual who receives this vaccine, they don't get the disease. Now, a very high number would indicate that more patients would need to be treated to have one successful intervention. So let's say that out of 10 people who take this medication, it's effective in 6. So it's less effective. Now, speak about odds. So what are odds? Odds tell us how likely something is to happen compared to it not happening. An easier way to imagine this is imagine we're going to play a dice game, and our goal is to roll a 6 for us to win. We can see this as I have a 1 in 6 chance to win, or out of all the sides on this die, one of them is going to give me a 6. So that's one side that's going to give me a win, but there's 5 sides that are going to give me a loss. So we can see this as 1/5. So probability of winning over the probability of losing. That's what odds are. So odds is going to equal the number of people with the disease over the number of people without this disease. So in our scenario of smoking and lung cancer, out of the 100 smokers, 20 developed lung cancer, whereas the remaining 80 smokers didn't. So risk is 20 out of the total, but odds is 20 is comparing the two groups, who developed and who didn't. Now let's try this with a more common chance of a disease. Let's imagine that out of the 100 smokers, 99 developed lung cancer, and there was just one smoker who didn't. Or we could just submit this with anything else that's very, very common, like a common cold or anything like that. For rare diseases, you're going to notice that the risk and the odds are very close. But for common diseases, the odds could get a lot bigger than the risk. So you can see that the risk here is 0.99, but now the odds are 99 to 1. So it's a huge difference in that number. An easier way to understand this is you can use a pie chart analogy. So risk is you're comparing the slice of cake divided by the whole cake, but odds is a slice of cake divided by the rest of the cake. A few key points is that risk is always between 0 and 1, or 0 to 100%. But odds could be greater than 1 if there are more people with the disease than without, like before when you said 99/1. Now, what's an odds ratio? An odds ratio is a way to measure how strongly an exposure is associated with an outcome. So how strongly is smoking associated with lung cancer? This is going to compare the odds of an event in an exposed group to the odds in a non-exposed group. So how likely is this exposed group to get this disease compared to the odds of this non-exposed group getting the disease? And we can also compare the odds ratio with the relative risk. So relative risk compares risk between groups, so risk and exposed versus non-exposed. But odds, it's going to compare odds between groups, like I said before, odds in exposed versus odds in non-exposed. Similarly, for rare diseases, the numbers are usually smaller, but for common diseases, the odds ratio could get much bigger than the relative risk. So let's go through an example, staying with the same track of smoking and lung cancer. So for the odds ratio, you can see how we're comparing the odds of these two groups. So it's not comparing 20 out of 100, but 20 who got the disease versus 20 who didn't. And for non-smokers, the same thing. So 20/80 is going to give us 0.25, and we're going to divide this by 0.02, which is the result of 2/98. And we're going to get 12.25, which is going to tell us that the odds for smokers getting cancer is 2.25 more times than the odds of non-smokers getting cancer. Now, for odds ratio and relative risk, this is going to help us understand it a bit better and what these numbers actually mean. So they both measure how much more or how much less likely it is for disease in the exposed group compared to the non-exposed. It's always comparing two things. If it's equal, that means the exposure makes no difference. So me smoking has no impact on if I get lung cancer. If it's greater than 1, then that means that exposure increases risk. So me smoking increases my risk of getting cancer. And now if it's less, obviously smoking doesn't decrease my risk of getting lung cancer. We could say wearing sunscreen decreases my risk of getting skin cancer. That would be an example of that. If anybody has any questions, please feel free to ask, but these are my references. Thank you.
Thank you for that excellent presentation. Are there any questions, or Dr. Lopez, do you have anything to add?
Gabe, just wanted to say that that was a great presentation. Going back to, I guess, some of the journal articles that we read yesterday, some of them did include like relative risk and different risk factors. So I think you did a great job of breaking down each one and really how we can use that knowledge to analyze further papers.
Yeah, definitely. I think, and let alone that you brought in the Amboss questions and that. I think, like physics, you have to memorize a formula for this. And as long as you have the variables, you're going to need to calculate it. Whether you take the MCAT, whether you take statistics, whether you take the core statistics, or you take, you're going to come across this question. So, and then like literally it'll be step one as well, a question on step one. So you definitely need to know this formula. It's typical in healthcare to be used. So as long as you know it, you should be okay. And like I said, the more important thing is as long as you memorize the formula. Okay.
Thank you, Dr. Lopez. Our second intern is Nadira from Adelphi University. Nadira will be presenting on relative risk and interpreting 2 by 2 tables. Nadira, when you're ready, you can share your screen.
So as Lawrence mentioned, my name is Nadira Peaks. I go to Adelphi University, and today I will be presenting on understanding relative risks. So what is relative risk? Relative risk is a statistical measure of the risk of a certain event happening in one group compared to the risk of the same event happening in another group. Relative risk is also known as a risk ratio. It can help answer questions like, does smoking increase the risk of lung cancer? And understanding relative risk is especially important when conducting observational studies, such as cohort studies. Cohort studies are a type of observational study that compares groups of exposed and non-exposed individuals. Both groups are then followed over a period of time in order to examine an outcome. So it's the research question that came up in Gabriel's previous presentation. Does smoking increase the risk of lung cancer? And to the right, we see a picture of the smoker, which would be considered the exposed group of individuals, and the non-smoker, which would be considered the non-exposed group of individuals. The two arrows represent time, and the outcome represents lung cancer. When collecting data for cohort studies, it is beneficial to use a 2 by 2 table. So what is a 2 by 2 table? A 2 by 2 table is a helpful visualization of where individuals are separated based on 2 factors. They help visualize the frequencies of observations falling into 4 possible combinations of these variables. So this is an example of a 2 by 2 table based on the research question above here. The number of individuals is 200. And based on the table, we can see that there are 20 individuals that are smokers and have lung cancer. There are 2 individuals that are non-smokers and have lung cancer. There are 80 individuals that are smokers with no lung cancer, and there are 98 individuals that are non-smokers with no lung cancer. The total number of individuals with lung cancer is 22, and the total number of individuals with no lung cancer is 178. How can we calculate relative risk? So relative risk is the probability of the risk ratios among the exposed and the non-exposed group. So we can do this by calculating the incidence risk among an exposed group divided by the incidence risk among a non-exposed group. The A, B over A plus B and C over C plus D represent the formula for the 2 by 2 table. 20 would be considered A, 80 would be considered B, 2 would be considered D, C, and 98 would be considered D. If we calculate the relative risk based on the research question, we can see that it's 20 over 100 divided by 2 over 10. That gives us an answer of 10. So based on that analysis, we can say that the relative risk of smokers developing lung cancer is 10 times higher than in non-smokers. So when interpreting relative risk, we know that relative risk is in essence a probability comparing the risk of events between two groups. So relative risk of 1 indicates no difference in risk between two groups. Relative risk that is less than 1 indicates a decreased risk in the exposed group. A relative risk that is greater than 1 indicates an increased risk in the exposed group. For example, if we say that we have relative risk equal to 2, that would mean that an outcome is twice as likely to happen. So there are many applications of relative risk. One application is in policy and decision making. It can inform health guidelines and safety rules. Another is in sports medicine and injury prevention, which is especially important. It can evaluate injury risk under different conditions. And another is in risk communication, which helps risk to patients, athletes, or to the public. It's a very good communicator. We know the relative risk provides a clear, evidence-based way to compare risks between different groups and guide better decision. So relative risks are not applicable for case control studies. Case control studies are retrospective, meaning they compare the past of individuals that already have an outcome to individuals that do not have an outcome. Relative risk is calculated by dividing the risk of developing a disease in the exposed group by the risk in the non-exposed group, as I said before. Since incidence is not known in case control studies, relative risk cannot be directly communicated. You can use odds ratios instead. So here are some of the key takeaways that we can find from relative risks. We know that it quantifies the probability of an event occurring in an exposed group compared to a non-exposed group. 2x2 tables are a useful tool to visualize and calculate the frequencies of outcomes across exposure groups, simplifying the computation of relative risks. Relative risk is used in cohort studies, while odds ratio is used in case control studies. Here are some helpful resources outlined that go more into depth of relative risk. These are the specific references that I use in this presentation. And thank you. Are there any questions?
Thank you for another excellent presentation. Does anyone have any questions or comments? Dr. Lopez, did you have anything to add?
Sure. Thanks again, Nadira. Yeah, I think when you're doing relative risk analysis, make sure we understand this is different than risk assessment or risk analysis. Relative risk, and again, relative risk has several limitations. It can overestimate the impact of the intervention or the exposure. So make sure you keep that in mind. It won't be as common as you think it would be, and it doesn't directly tell us the absolute risk of an event occurring, overall public health impact. So there's limitations when you use relative risk, and that's why it's important that your analysis is, or the data used in your analysis is the best as possible, because when you use the relative risk, then you just carry on the limitations of the data set. So make sure it can be misleading, if not interpreted alongside absolute risk measures. That's why I want to make sure everyone understands that. So overestimation of the effect is always the number one problem, right? And then, lack of absolute risk information and misleading interpretations. So when you do these, make sure. That's why when we do our analyses, we include confidence intervals, relative risk, we include p-values. We put in as much supporting data in the analysis to validate it the best we can. And I think even though we've done just a few papers, we've tried to put the best foot forward on our analyses. And I think that's something that everyone needs to keep in mind, when you're doing this. Okay, everyone?
Yes.
All right.
Thank you.
Our third intern is Ritvik from Georgia Tech. He'll be presenting on bias types in research. Ritvik, when you're ready, please share your screen.
All right, hello everybody. Today I'll be presenting on bias types in research. So what is bias in research? So bias refers to any systematic deviation from the truth, whether intentional or unintentional, that distorts the conclusions of a study. It can happen during data collection, analysis, interpretation, or publication. Bias often leads to false positives or negatives. So there's multiple different types of bias. It depends on which research stage you're in. For example, there's pretrial bias, bias during trial, and bias after trial. And in this presentation, we'll go through the different type of biases in each trial. So first, you have pretrial bias, and this includes selection bias, which the sample is not representative. And then you have channeling bias, where group assignment is influenced by patient clinical characteristics. And then you can also have volunteer or admission bias, where it's non-representative self-selection. And an example of selection bias is during pretrial bias is that, for example, a researcher only recruits young and healthy participants for a drug trial. Next, you can have bias during a trial. So some examples are recall bias, where there's memory errors in self-reporting. And then there's performance bias, where there's unequal treatment between groups in the study. And then there's transfer bias, where dropout rates differ by group. And then there's also misclassification bias, where there's wrong outcome labels on the results. And these biases distort collected data. So there's bias after trial, and a big one is interpretation bias, where it overstates causality and also an inappropriate extrapolation. And clinically, when they state it's clinically meaningful, but this can be misleading at times. And then there's also publication bias, where positive results are published more, and then null findings are often ignored. A quick note, selective reporting leads to distorted literature. So next, there's consequences of bias. So some consequences of bias are that it produces false conclusions, and some big effects of these are it affects clinical decisions, guidelines, public policy. And some things to note is that confounding and bias can't be fully avoided, but they must be recognized and disclosed to whoever you're presenting to and in your study, so people can take a note of it and keep that in mind. And once again, every study has confounding variables and limitations. You just got to make sure to recognize it and disclose them. So what are some ways you can reduce bias as a researcher and when you're conducting your own research study? So in the design stage, one thing you can do is use random sampling to ensure representativeness, and also apply inclusion-exclusion criteria that are fair and clear before you begin. And during data collection, use blinding to prevent participant or research influence. So basically, blinding is when either like the participant, researcher, or the data analyst doesn't know who's in each group. And this will also reduce bias. And another thing you can do is standardize procedures and definitions. And lastly, during analysis and reporting, pre-register analysis plans and avoid p-hacking or selective reporting. P-hacking is basically, I mean, the p-value tells us like the significance of an outcome. So sometimes researchers will play with that significance value and falsely claim that something's significant when it is not, just so the results look good. So definitely avoid that because it is very misleading. And then once again, acknowledge limitations and confounding variables. These are my references, and I'm open to any questions. Thank you.
Thank you for another great presentation. Are there any questions, or Dr. Lopez, do you have anything to add?
Yeah, give me a second. I'm just looking for something I wanted to add to that. Just one whole second. But anyone else has a question?
Yeah, I guess to add, as we look forward with our research process, be sure to avoid these types of biases as they could definitely impact the results. And we want to conduct the most scientifically accurate, but also with data validity as much as possible.
I apologize, Redford. Could you go back a couple slides in your presentation? And I want to see if this jives with what I was looking for. Yeah, so I think one thing that's kind of unique, particularly next slide if you don't mind.
Oh, do you want me
Yeah.
to go
So
backwards?
no,
Okay.
no, that's fine. It's just you didn't include it in there. That's okay. I wanted to make sure I covered it. Give me a whole second, son. So when we've probably talked about different biases. There's multiple biases beyond of what we're talking about here, and let alone what Ritvick dabbled in. It's really quite extensive. Um, I know we have a graphic, so just give me a second. All right, found it. All right. Of course, when I try to look for it, I can't find it. Let's just go over it. So more importantly, right, with our data, we have the potential when we saw the articles we discussed yesterday. What was a bias that we saw in one of the articles in the data collection? We had varying data collectors. That's why we kind of try to standardize our data collector by using athletic trainers, right? We're making sure that all of them have the same education, ideally, the same training, the same background. And not only that, but there's been papers that publish that validate that the diagnostic capabilities of athletic trainers are similar to that actually of sports medicine physicians. That the analyses or the diagnosis that they come up with are very similar. Luckily, it's due to the fact that um, um, I apologize. It should be the fact that these athletic trainers are all coming with the same perception or same workbook. And that's why I've shared the sports medicine consult with y'all. So this way you can all look at it from the same perspective of what we're looking at it from. When we're looking at it, also why we emphasize so importantly the consensus statements, right? We want to make sure that the data is collected appropriately according to the same definitions. And some of you who have already started writing manuscripts or things like that see that some of the definitions are already kind of off in a couple of words. And this is where it gets a little tricky, because if the data is not collected universally by the same education or the same data collector, and the data, you end up with biases. Let's first start with the data collector. The data collector, if they come up from different backgrounds, their interpretations may be different. So we have biases between physical therapists, doctorates in physical therapy, athletic trainers, physicians, and then our trained research data collectors. But we try to standardize that by providing the handbook, the manual, and standardizing the avoidance of those biases. And we put that in our limitation section. We emphasize that we try to limit definition biases or consensus biases by making sure we standardize and train the athletic trainer or whomever is our RDC for that event. So, interpretation biases, right? These are the people. So, Willie is going to interpret definition maybe a little bit differently than Ritvick, right? Because Ritvick's got an athletic training background. Willie has a sports medicine science background. So, there are differences. But we try to curb those biases by making sure that, Gabriel and Larry, who come from the medical world of nursing and medicine, that is going to jive with the data or the interpretation of the definitions that, so we make sure we curb those biases. That's one. Then we have now written form of the RISE reporting, which we're going to what? We will mitigate those biases of transcription biases, right? So when we get that data and then we transcribe it into an Excel sheet, there may be biases there, but we will mitigate or limit that now by doing an online injury surveillance system. You see what I mean, right? We're always improving or trying to improve what we can work on. And these biases, vary. I know I had a small graphic or something. Ritvic, look it up. There's a graphic out there and it had all the different biases on it. And I just can't I can't find it. I just don't understand why. But more importantly, like I said, it's definitely out there. And you got to remember, then also, I think what was kind of unique is, do we have one more biases in our data set? And we need to make sure we emphasize that. So you see, but we don't. So do we have all the severe injuries only coming to the medical tent, right? Those who know that they're hurt, right? Those concussions, those fractures, those dislocations, they're definitely coming for help, right? Because they're injured. They know that they're hurt. So, but we don't, because we end up with a majority of minor injuries also, right? So, Philip, who's seeing the data set, right, Phil? You know what I'm talking about, right? There's a large percentage of minor who helped. Sorry, yeah. So Lily helped with the slide with that on catastrophic injury. So we have a majority of non-life-threatening injuries. So we're not just capturing that bias, but we need to keep that in mind, that could be it, right? So, Harry, when you were in lacrosse, you probably wouldn't have gone to the medical tent for a small injury, but you definitely did if you rolled that ankle and you're like, darn, I can't juke. I can't propel off that foot anymore. That's going to be a limitation. And that's really what it comes down to. Luckily we're seeing all types of injuries and our data set reflects that. So it can't be, but these are things that, like I said, I think we were just talking in the conversation before. I'm making sure that we're looking at that data set overall. Anyway, on that note, like I said, there's multiple biases, and then also, how do you know which athletes to approach? Are you going to be approaching? We discussed this right in the beginning. Are you going to be approaching the athlete that's throwing tables, that knows his championship, run is at an end? There's a biases there. So are you going to approach them? You have to approach them. And let me tell you, if you don't work on this bedside manner to approach this athlete, and this is what I mean, when you go to the National Club Championships, it's nothing like the smaller events. Philip, so you're the only one. So let's discuss this. Philip, you've gone to a local event in Michigan to collect data, and you've gone to the National Club Championships. Did you find it equally challenging, or did you find that there was maybe bias on how you approached the clubs that, I guess, rose to the top there at the championships?
Yeah, I'd say that the sort of atmosphere at the tournaments differs a lot. So in
No, it's way,
regards
way different, right?
and in regards to injuries at a local tournament, when a player goes down, it's mostly, hey, go like the teammates, from the perspective of teammates, they just want their teammates to go to the tent to get whatever treatment they can and just to heal up. But at the club championship, because that's the end of the season, that's when they just want to leave it all out there. It's a lot of concern of like, hey, this needs to be dealt with immediately. And there's like a lot of anxiety around that. So if a player gets a very serious injury, there's a lot of anxiety, not just from that player, but the team as well. So it is difficult to speak to that player specifically, and you do have to have that bedside manner.
Thank you. Yeah, like I said, so you could definitely see that there is a bias there, selective bias, if that's probably the one we should be using or discussing there, on how do we choose which athlete to approach and how you approach that bias, because you can imagine that they're quite upset. All of you have been athletes, you know what I mean. When you're winning, it stinks when you're hurt, you know, and you just don't want to address it. And again, you have to kind of make sure we conclude or include all of that. But luckily, like I said, it's run so well, the club championships, that we don't have that issue, fortunately. And let alone, I think, Philip, you walked with me and you made sure, you see how I make sure the coaches know I'm there again. They know that I'm there to do the right thing. And I make sure that the captains, the coaches, we try to go, we're going to fly in, make sure we speak with the teams. And it's that they know I'm going to do the right thing with them. You know what I mean?
Yeah, definitely
And
maintaining that reputation and showing face at the beginning so that they're aware of what to expect and also knowing your reputation from previous years. It builds off of that going forward.
yeah, like I said, so it's a very unique thing, bias, and make sure, I want to make sure we include that in all our papers going forward, make sure we put that in limitations. We want to make sure we discuss those things. We don't need to hide anything. What we want is to produce a paper or a study that can be replicated for the benefit of athletes overall. And that's really what we're doing. When we put our paper out and we put our methodology out there, we want to make sure that everyone can replicate that. We've given them everything they need. They want to do it the right way. Don't do it the wrong way. We're lucky to have the teachers we have. So we put that out there appropriately, and that's why we have the reputation we do. If we can continue doing that and address biases appropriately, I think there's benefit for that. Rifik, did you find anything on that graphic? You get what I mean?
I mean, there's some good ones online, but I didn't know if this was exactly what you're talking about. I can send the links if you want to take a look at them.
No worries. Just like I said, if you want to share an image with us, like I said, make sure that includes, you could probably put in their research biases.
Yeah, I can show real quick.
Yeah, share it with everyone so we can go over that a second.
Yeah.
There's different biases in research, right?
Yeah. So I don't know. I thought this one was decent.
Yeah, bring that up there. You see, so you don't have to copy it, son. Just leave it open a second. Let's say,
Okay.
so, right? Stereotyping. Yeah, that's also a big thing. Stereotyping, thinking that the best player is not going to be hurt. That I think there's a big problem. Their key player, you just have to be on top of them. So, yeah, data, I probably would, different types of bias and research. I would probably put different types of research data bias. Yeah, but go to that one there on escape. Yeah, that one there below. Third row down.
Are you talking about this one?
No, the one to the right there, son. The one with the circle.
Oh, these.
No, the one on the right there. Well, down one more row and to the right. Fourth, right there. That one. Yeah, see that one? Types of bias, research, confirmation bias, observer bias, reporting bias. You see, this is what we're talking about here, right? So recall bias, right? We've talked about that, right? With the certain studies that use recall data and for authors not to comment on recall bias, right? Selection bias, sampling bias, confirmation bias. And I think, like I said, reporting bias. That should include transcription bias. There should be one more in there. You know what I mean? Whoever's lying that they don't use Excel for their research is full of it. You know what I mean? Right? Excel is your number one tool for data organization. You find me another tool. I don't know what other tool they use, but for those who don't incorporate that in transcription or data, right? We've seen it when we move our data. Some of the columns don't align. God forbid we miss a data column, or sorry, a row of data that's inappropriate and misaligns our data. So, like I said, I think that's a good one. The research bias, right? The observer bias, time interval bias. That's another thing. That's why, if you notice, when we do our surveys, we use one window of data collection, because you can capture it at that juncture, but if you try capturing it year in, year out, you need to kind of mentally or prepare for that longitudinal data look at, instead of comparing 2 time points. It's very different if you collect data year after year after year than collecting it at 2 different time points. And that's another thing I think with data. Did we know all this when we started? No, I'm not saying we did, but we improved along the way. You can close this out there. Thank you. Thank you. All right, everyone. So I think it's an important point to take into consideration when you're looking at data, or even trying to get your research projects going, whatever it is. And like I said, Larry, if you don't think you're going to be crunching the data in pharmaceuticals for, post anesthesia opioid use is what I did for the chief surgical resident, you're going to be doing it, dude. You're going to be doing that, and you need to say, oh, you'll just sound much more knowledgeable. You get what I mean? You get what I mean? They'll lean on you more, right? Like I said, if they want to give credit to you, you'll be happy, but the director knows. The director knows how this works. You know what I mean? They know that you guys are doing the work. They know that you're all doing the labor. That's the way it is. Like I said, if I can give you the skill sets to help you move ahead, and like I said, everything that we've incorporated and everything that we're doing always has that reliance on when you guys go out. And I think this is really a big, big problem. Nadira, Asha, you guys are going to end up in some capacity dealing, maybe not right now, but maybe you will be dealing with healthcare professionals. You get where I mean, Nadir, right, Asha? Whether you go in chemical engineering or you go into computer science, you will be dealing with healthcare, and you're going to have to know this stuff. You will have one up on your peers in this arena. You could just imagine, right? Now that I put it out there, Asha, you will understand that you will be dealing, right? If you don't think you're going to be dealing with the FDA, right? OSHA, FDA, everything that you're going to be encountering, and then let alone you're going to be dealing with different healthcare professionals who are concerned about chemicals and their influence in people. And let alone, Nadir, if you do encounter, you're going to have to need to know how to do this as well. Any questions on that, anyone? I'm sorry we were all over the place, but I think it's a very important point. And I think Dr. Coleman gave us a talk on biases back in the day. Any questions, anyone? Okay. Like I said, sorry, Larry, go ahead.
All right, well, that concludes our call for today. We thank everyone who joined for our Rugby Research and Injury Prevention Group analytical series, and we will see you next week. Thanks.